All right, hello everyone. It is 12:01, so we will get started. Thank you for joining us today and welcome to today's webinar, which is the second of our paramedic series that will address the mental health among Canadian paramedics during infectious public health crises. My name is Corey Jameson and I'm the Public Relations Intern at the Canadian Institute for Safety, Wellness and Performance, which is hosted at Conestoga College's School of Business. Frontline healthcare workers such as paramedics have risen to the challenges that COVID-19 has presented, playing a vital role in maintaining public health and safety in the face of the health crisis. Paramedics, however, are a high-risk group of workers for developing mental health injuries due to a unique set of stressors. Paramedic service organizations have expressed their concern that the COVID-19 pandemic will be an additional significant stressor for their frontline staff, further increasing the prevalence and severity of mental health injuries. This project aims to rapidly mobilize solutions and expertise to develop a rapid guideline for the paramedic community to prevent and manage mental health injuries during and after the COVID-19 pandemic. Today's webinar will present key informants' perspectives and experiences on how the COVID-19 pandemic has affected them, as well as the mitigation strategies organizations have implemented to support the mental health of their workforce. Our speaker for today is Bronson Du. Bronson is a research scientist at the Canadian Institute for Safety, Wellness and Performance. He has expertise in developing organizational level guidelines and resources for the prevention and management of work disability, and in integrating human factors and ergonomic principles into industry-specific design standards. He applies a systems approach for data collection, analysis, interpretation, and reporting to inform the development of workplace interventions. The format for today's webinar is a presentation by Bronson, and then there will be time for a Q&A session near the end. So if you have any questions, please use the Q&A function of the Zoom platform, and we will get to them near the end of the webinar. I will now hand it over to Bronson to begin his presentation.
Thanks, Corey, and good afternoon, everyone. I'm delighted to be here today to provide the second webinar of this four-part webinar series. And so, as a quick background, our research team has been working closely with the Canadian paramedic community on various projects to support paramedic services in improving performance, health, safety, and well-being. And over the past year, we have been developing a guideline for addressing the mental health impacts of COVID-19 amongst Canadian paramedics. So in this webinar series, it's used as one of the many platforms to launch this guideline and disseminate the research and development associated with it. In today's webinar, I'll continue to talk about the research and development that's gone into creating this guideline and share paramedics and organizational leaders' experiences in responding to the first wave of the COVID-19 pandemic. Specifically, I hope to answer two questions. What are the changes related to paramedics that paramedics faced during this time? And what have paramedic service organizations done to mitigate those stressors? On the agenda today, I'll first provide a quick recap of last webinar, and then I'll jump right into our interview study to try and answer those two questions. All right, so first is the recap of webinar 1. In the last webinar, we talked about the high rates of operational stress injuries, or OSI amongst paramedics, noting that 49% of Canadian paramedics screened positive for at least one mental disorder, and that there's a need to consider supports for a range of mental health conditions in addition to the traditional trauma-focused interventions. Because it's not only PTSD that is of concern, depression and anxiety are actually more prevalent amongst this population group. We also discussed how paramedic work was inherently high stress with limited job autonomy, and how organizational and operational workplace stress might play an even larger role on the mental health of paramedics than exposures to potentially psychologically traumatic events. And this really has been the aim of our research, to develop tools such as guidelines, such as this guideline, to support paramedic services in addressing these OSI-related stressors in the workplace. That is to say, our research really focuses on what the organization can do as opposed to what the individual can do, or the types of clinical treatments that mental health professionals can and should provide. Last webinar, I also presented 2 research studies that were conducted prior to the pandemic, and that would lay the foundation for the guideline. So both of these studies built upon this disease prevention model for intervention, which consists of interventions to help maintain good health and minimize risk of OSI. So that's primary prevention indicated by the top green box. It also consists of interventions to identify and support individuals with early signs and symptoms of OSI. So that's early detection and intervention indicated by the second yellow box. And lastly, but certainly not least, there are interventions to support those recovering from work debilitating OSI. And if or when the OSI becomes manageable, work reintegration. So that's indicated by the red and yellow boxes on the bottom for disability management. And so through an environmental scan, we built upon this model and identified the recommended practices for paramedic services to implement at each level of intervention. And we also talked about the desired organizational elements that were identified through key informant interviews to address OSI at each of these levels as well. So if you'd like more information on these studies, the reports can be found on CISWP's website. The interview study is now in press for publication in a journal called Work. And there are a couple webinars going over this model more thoroughly on our YouTube channel. For the most of last webinar, we went over the research and evidence surrounding mental health of paramedics during infectious disease outbreaks, their predicted willingness to report for duty, depending on various pandemic situations, infection prevention and control training, organizational pandemic preparedness, and pandemic vaccine acceptance. So all this research that we talked about were identified through a systematic search for scientific literature on the mental health of paramedics during infectious disease outbreaks. A concept map of all the significant relationships identified through the review was also presented. And so here we talked about 4 organizational interventions that have shown significant impact. There was a 30-minute pandemic preparedness training program that significantly increased paramedics' intentions to use PPE, receive vaccines, and it also increased their willingness to report for duty during a pandemic. There was also a mandatory vaccination program policy that was out of the States, and an organizational-wide vaccination campaign that significantly increased vaccine acceptance. And lastly was a ambulance ventilation system that increased air change rates and reduced airborne particle concentrations. So those were the 4 organizational interventions. We also talked about how several factors related to attitudes, beliefs, and feelings, such as having a sense of competence, sense of personal and family safety, sense of obligation, how those were significant factors for favorable behaviors or behavioral intentions during an infectious disease outbreak. So favorable behaviors being things like willingness to report for duty, willingness to wear PPE, and acceptance of the pandemic vaccine. And so this literature identified a need for strategies to modify attitudes, beliefs, and feelings in addition to the traditional approach of transferring knowledge in training programs. All right, so that was an overall overview of the last webinar. Overall, we presented the research that was available that would lay the foundation for our guideline. In today's webinar, I'll continue to talk about the research in developing this guideline by sharing the experiences of paramedics and organizational leaders in responding to the first wave of the COVID-19 pandemic. Now, the data that I'll be presenting to answer these questions will be based on key informant interviews. So these interviews were conducted during the peak and lull of the first wave of this pandemic. That was last year between mid-April and mid-August. And from this study, we wanted to better understand what was actually happening in the front line. We already had a lot of data from previous research about the existing and suggested practices for addressing OSI during regular operations. And the scoping review that we conducted had identified several stressors and mitigation strategies related to paramedics working during infectious disease outbreaks. But we also conducted this study to help ensure that the guideline would be relevant and pragmatic for Canadian paramedic service organizations to use and implement before and during an infectious public health crisis. So yeah, we interviewed paramedics and organizational leaders from services all across Canada. And we asked them about how the pandemic has changed work for paramedics. What were some specific resources, programs, or policies that organizations have implemented to minimize mental health challenges? And what initiatives could be further developed by organizations to support paramedics? So the interviews range from half an hour to over 2 hours with an average of 65 minutes. All the interviews were audio recorded, transcribed, and thematically analyzed. Again, just to keep in mind, our findings speak particularly to the first wave of this pandemic. And as you see in the chart on the right, there's been a second and third wave of cases since then. So we need to take into consideration that frontline workers have been dealing with this pandemic for the past 16, 17 months. And these interviews were conducted 1 to 5 months in. So there's definitely going to be new and unique stressors and mitigation strategies that have emerged since then. But nonetheless, these interviews can give us a sense of what was happening during that time in the front line. So from the interviews, 5 topics emerged that we'll discuss further today. We'll talk about the overall work atmosphere and mental health outcomes, the increased amount of information to uptake and disseminate. Third is infection prevention and control. And we'll also touch on scarce resource and triage, as well as staffing, call volume, and workloads. Let's start with a quote that summarizes the overall work atmosphere right at the onset of the pandemic. A platoon supervisor shared with us, "The level of stress and anxiety has definitely increased amongst paramedic staff. There is a lot of fear being exhibited by paramedics who are out on the front lines. There has been so much information flowing and it changes so frequently that the stress and fear increases while trust decreases. There is fear of contracting COVID and there is fear of bringing it home. There is fear that PPE will not work or that there is not enough. As a result of the fear and lack of trust, some have taken the attitude to take care of themselves. We have some staff that we have had to put on isolation precautions, and some have been tested for COVID. There is a fear and anxiety that comes with this as well. It's amazing to see how fear can grip a normally logical group. Paramedics are well educated and adaptable, but fear brings them to a point where this is out the window." So that quote really summarized and encapsulated what was going on at the very beginning, how there were increases in feelings of fear, anxiety, hypervigilance, distrust, and uncertainty in the workplace. Needless to say, there's an increase in perceptions of risk associated with a job, having a fear of contracting COVID and bringing it home, fear that there will be a surge of cases, fear of PPE shortages, and that PPE won't work. And so this was also the time where there was debate and uncertainty on whether people should be wearing face masks or not. And so interviewees shared that many workers were dealing with this internal conflict between their professional and personal obligations. And the following sentiment was shared, commonly shared and described by our interviewees. "I no longer looked forward to going to work because I didn't know if I would bring the virus back home." And this is not something surprising. We know from the literature that responding to novel infectious disease outbreaks is rated as one of the highest for fear and unfamiliarity. We also know that concern for family safety was the most important barrier against reporting for duty. In terms of new cases of OSI or new OSI related disability claims, I think we actually asked this question too early on. Interviewees shared that they have not noticed an increase in reports of OSI despite the elevated risk, elevated levels of anxiety and stress in the workplace. However, that is not to say that we are not seeing a surge of OSI right now and that we are not going to see one in the future. I've spoken to some of the organizational leaders more recently, and they shared that there's now significant wait times to see a mental health professional within their mental health referral network. Our interviewees have, however, shared that at the onset of the pandemic, that has triggered pre-existing OSI in those who responded to the SARS pandemic back in 2003. On a bit more on a positive note, leaders from some services shared that there was more empathy and patience in the workplace, stating there was also like a mega increase in this idea that everybody was in it together. People seemed to have more patience with each other. And this is consistent with the phases of psychological response during an outbreak, where in the early part of the active phase under heroics and surge to solution, workers may feel an increased camaraderie as staff cross boundaries and work together. And as mentioned, it's the later phases, the disillusionment and exhaustion phase, and the recovery phase. That's where we need to keep an eye out for developments of OSI. And lastly, there was a sense of luck in the regions that had lower case counts. Okay, so implemented mitigation strategies. Many of our interviewees shared that their organization implemented numerous initiatives aimed to addressing workers' core concerns of contracting COVID-19 and bringing it home. So they did this by ensuring that there was enough PPE, first of all, and sometimes this meant purchasing a few hundred items here and a few hundred there, wherever they could find PPE, and or even substituting for other styles. Some offered laundry or dry cleaning service so that workers could leave their dirty uniforms at work, go home and clean street clothes, and not worry about needing to change out of their work clothes in the garage and running to the laundry room right when they got home. Many of the organizations that we spoke to also provided lodging and accommodations for workers to self-isolate from their loved ones and cohabitors. And some provided universal COVID testing for all the workers as well. Many also hosted town halls to inform community and family members about their infection prevention and control protocols that were in place to keep workers and family members safe. And this aimed to help reduce the worries from family members and reduce the stigma that paramedics are exposed or dirty or contaminated. For some services, this helped to reduce the need for paramedics to answer a bunch of health and safety related questions from concerned, rightly so, concerned family members and cohabitors. And that allowed them to decompress a little bit better when they got home. So many of these mitigation strategies were solution focused to address the safety concerns of workers and their families. In terms of mental health specific supports, there was increased communication about the resources that were available, and there was an increased promotion of good mental health practices and adaptive coping behaviors, such as getting adequate sleep, proper nutrition, exercise, and staying connected with their social support system. So that was about the overall changes to the work atmosphere and general mitigation strategies that were implemented early on. We can dive deeper and look at some of the topics individually now. So one of these recurring topics was the overwhelming amounts of information to take in and disseminate. Many organizational leaders shared that they put in a lot of overtime trying to understand what was going on and figure out next steps. This quote summarized the challenges that our management interviewees faced. I know from a management standpoint, I probably did in the neighborhoods of 60 hours of overtime for the month of March, April, and May. The inability to unplug as things were basically changing on a daily basis. A typical government, you watch government make announcements at 4 o'clock on Fridays where, we'd be in the office all week working away and hoping for a little bit of a downtime on the weekend. And then something would totally change and go a different direction. And oftentimes the timing of it was very difficult to actually unplug. So again, in terms of information uptake and dissemination from the management perspective, they carried a very heavy load to ensure that they were doing the right things to protect their employees and maintain service capacity for the community, which resulted in a lot of overtime. Now, from the paramedics' perspective, they also had a lot of difficulties keeping up with all the rapidly changing information and trying to make sense of the policies and procedures that were put in place. one paramedic noted, it was very overwhelming because policies were changing in a blink of an eye. And with our schedule as paramedics, a lot of us work 4 days on, 4 days off. So you're almost coming back to work with a clean slate, and you had to just try to learn everything over again. Now, this constantly changing and overwhelming amounts of information led to confusion about whether paramedics were doing their jobs correctly. So one of our interviewees shared, I had multiple emails on a daily basis that contained changing information to the point of oversaturation and confusion and contradiction with information. I received 65 emails over a 14-day period from my employer in reference to COVID-19. With all the conflicting information, I felt there was really nothing I could do to protect myself and my family. It has impacted my performance. And another one of our interviewees noted, there's no time necessarily to be slogging through 25 emails and trying to figure out what the latest update is. You ended up with a group of people who were feeling less capable than they usually did in their position, which was adding to and exacerbating any stress and anxiety. So organizations have done multiple things to try to reduce paramedics from being overwhelmed with information. For one, they streamlined the sources of information. Some used information bulletins, so everything that paramedics needed to know were all in one place. And the key here was that to highlight all the changes and updates so that people didn't need to review the entire document and identify what the changes were. Some organizations directed all communications to the Emergency Operations Center to ensure that the information were consistent and coming from one source. Also, many organizations held virtual briefings at the start of each shift to update all workers on what they needed to know coming into their shift. And as I mentioned earlier, many held virtual town halls to offer the community and family members, as well as paramedics, to ask questions and better understand the situation and the rationale behind some of the protocols. So many of these communication strategies are in line with the recommendations identified in our literature review. However, something new that we hadn't expected is the amount of inconsistent guidelines from different agencies. And this was because everything happened so quickly and it was also unprecedented. And so this led to a lot of distrust and workers challenging the decisions of their organization. So this means that there is a real need to ensure that communication was transparent and acknowledges an understanding of the various guidelines that are out there and providing a clear rationale for the organization's decisions. Another topic that emerged was infection prevention and control. Some of the protocols that were put in place made it very challenging for workers to take care of their basic needs. For example, one paramedic shared, "We have been instructed by management that we must mask at all times in the ambulance and cannot eat or drink in the ambulance or hospital. We have went as long as 10 hours without food or drink." And so this paramedic works in a rural location that has been dealing with a lot more long distance transfers for patients with COVID-like symptoms to hospitals that were designated to deal with COVID. In terms of the key changes for infection prevention and control protocols, some services only required medics to put on PPE when the patient had COVID-like symptoms. And so this created a stressful situation for paramedics who arrived on the scene, screened the patient for symptoms, and found that they had to go back to the ambulance and put on full PPE before responding. And so that same paramedic shared with us, if there are any of those symptoms, we are required to return to our ambulance and don full PPE, which includes N95 masks, gowns, gloves, and face shields. In the case of cardiac arrest, we are not to enter the scene until we don full PPE. Of course, this delays response, and family members get very upset. And this sentiment was shared by our interviewees multiple times. Some organizations later implemented universal use of PPE to kind of remove the need for screening the patient. And I'm not sure if there's any changes with those policies now. There was also new requirements for self-screening, quarantine, self-isolation, and testing for COVID. And because of the broad range of COVID-like symptoms and the timing of when the pandemic was announced, so that was after March break and during the flu season, there were a lot of workers that needed to self-isolate very early on. And we'll talk a little bit more about that in a later section. Now, in terms of strategies to improve infection prevention control, everyone acknowledged that this wasn't anything new. Paramedics dealt with other infectious diseases during regular operations. However, many organizations provided refresher training, and they had to get creative with this because of physical distancing rules. So some organizations provided refreshers through online training modules, training videos, or one-on-one. So like having a health and safety specialist go around to answer any questions to ensure that paramedics are properly donning and doffing PPE. In terms of the workers who were in self-isolation or quarantine, organizations shared that they conducted check-ins to monitor workers' health and well-being and offer support in navigating access to services like medical care and mental health support services if that was needed. Some services also amended their collective agreements to provide workers with quarantine pay that doesn't count against sick time. And so this provided livelihood security for workers to take time from working when they felt unwell or have had unprotected exposure to the infectious disease without needing to worry about whether or not they would be paid. Again, a lot of these implemented strategies were consistent with the identified mitigation strategies that we found in the literature. During the time of these interviews, there were also a lot of media coverage about PPE shortages and flattening the curve and trying to reduce the possibility of overwhelming the healthcare system. And in response, organizations implemented strategies to conserve use of PPE and triage protocols to reduce transfers to hospitals. However, this combination was another source of stress for paramedics. For example, one paramedic shared, "We now have to do a count of the PPE that we have available in our trucks and at base every day, and we have to sign out and account for all PPE used as we do with our controlled narcotics. The thing that I find most stressful, though, is that in an attempt to limit PPE use, we have a policy where for calls that it is possible the patient may have COVID-19 symptoms, only one medic gets dressed in full PPE and goes in to see the patient. If the call is simple and the patient is not going to require transportation, then that one medic runs the whole call alone while their partner waits in the truck. I do not feel comfortable going into calls alone, and I do not like this change. In another organization, they did run out of regular masks and had to substitute for masks that were much less comfortable. They said, "We have run out of procedure masks at least twice. The masks we now use are so tight, they leave scratches and scars on our face. They smell terrible and have been causing headaches to staff members. It has been reported, but we are told that we have to live with it as they are the only masks they can get." And as I mentioned earlier, organizations try to reduce patient transfers to hospitals whenever possible as well. So to support the situation, many organizations implemented scarce resource protocols, which included conserving and substituting PPE and monitoring the supply of PPE. And as I mentioned earlier, organizations would be looking to purchase PPE wherever they could, couple here, couple there. They also provided decision-making aids and access to online medical consultants to assist paramedics in making judgment calls as to when to leave patients at home. A couple of our interviewees suggested that on top of monitoring the inventory of PPE, it was also very important to be transparent and communicate the inventory and the burn rate to employees. Because even if an organization had enough PPE and told the workers that, workers were still listening to the media talking about PPE shortages everywhere. And they couldn't or didn't fully trust it when their organization said that there's enough PPE and they didn't need to worry. So it would be, a suggestion was to communicate the inventory of the PPE. One of the organizations developed something called a virtual triage assessment center to give community members virtual access to a physician if they didn't have one or couldn't access their own at the time. And this helped to reduce the number of calls for paramedic services. Our interviewees also suggested the need for better emergency preparedness by ensuring that the organization had designated personnel for emergency response planning. Because from our interviewees, a lot of organizational leaders were actually seconded to these positions, which meant that they were starting behind the 8 ball in developing and implementing new programs in response to the crisis. And so a lot of the mitigation strategies that I have discussed so far were developed and implemented on the fly. And what this really means is that in order to improve emergency preparedness, there needs to be a designated personnel in these roles so that resources can be quickly mobilized in the event of a crisis. So obviously these roles need to be included in the budget plan in the future. And the last topic is associated with staffing, call volume, and workload. And this quote summarizes it. "There wasn't a concern of not having enough people to respond because the calls just didn't come in. They might have had a challenge getting butts in the trucks, but the trucks weren't really going anywhere." As I mentioned earlier, at the start, attendance decreased early on due to requirements of quarantine People were coming back from travel and it was flu season. But call volumes also decreased. So from my sense with the interviews, paramedic services weren't overwhelmed by calls, but this didn't mean that the workload decreased. So a commander explained, just because call volume was down, the fact that there's the increased amount of cleaning and PPE and all those things that went along with it, it didn't really feel like much of a break for the medics. Again, these points are very specific to the time of the interviews and the population that agreed to speak with us, which might have been services that were not as overwhelmed. Something that we found interesting and unique from the literature that came up was that, generally speaking, there was not much change in workers' willingness to work. Many organizational leaders talked about how their paramedic staff were committed to their peers and how they understood that it was their duty to step up in this unique situation. And one service actually pointed out that there was actually an increase in the availability of their casual pool because everybody's vacations were being canceled. And that's something that was not reported in the literature. Again, these points are very specific to the time of the interviews and the population that agreed to speak with us. And speaking to some organizational leaders more recently, after the second and third wave, they've been doing a lot more recruiting and hiring because of turnover, fatigue, and burnout. In terms of implemented strategies, some organizations have been hiring more workers proactively to ensure that staff can take their vacations during lulls within the pandemic. And this is different from hiring and recruiting because of turnover. To also manage the predicted increase in call volume, some organizations had set up the virtual triage assessment centers that I had mentioned earlier, and some have used social media outlets to inform the community about the appropriate use of paramedic service during this time. So yeah, these are some of the findings from our key informant interviews. In summary of today's webinar, we discussed the experiences of paramedics and organizational leaders in responding to the first wave of the COVID-19 pandemic based on these 5 topic areas. And a lot of what I've discussed today are probably things that you already knew, you have experienced, or have even implemented. So I'll try to give a takeaway that sums up everything. When we think about addressing OSI in the workplace, sometimes we automatically think about providing interventions like mental health training, identifying the potentially psychologically traumatic events, post-incident interventions, peer support, employee and family assistance programs, and mental health, access to mental health professionals. And these specific mental health programs are very important, but they're only one component to addressing OSI in the workplace. As we saw in the response to the pandemic, organizations have implemented a lot of solution-focused strategies to support workers' mental health by demonstrating the organization's commitment to protect workers' health and well-being and ensuring that their basic and informational needs were met. And so being able to get to the root causes of the stress has been critical because, well, no amount of mental health specific support programs can fix the fact that there are PPE shortages or that the service is insufficiently staffed to allow for adequate rest and recovery. So as a silver lining, there were a lot of great interventions and initiatives that came out of the pandemic, and many of our study participants did mention that they hope that some of these will stay once the pandemic is over. Just taking a step back, so far in this webinar series, we've discussed the 4 research projects that's been used to inform the development of the guideline. And so the guideline has now undergone stakeholder review, and we'll launch it in our next webinar. So looking forward to that. Well, that's the end of my prepared presentation. At this moment, I'd like to thank our funding sources, DRDC, for the projects that were completed prior to COVID, and the Canadian Social Sciences and Humanities Research Council on behalf of the College and Community Innovation Program, Applied Research Rapid Response to COVID-19 for funding the research and development for this guideline. I'd also like to thank my colleagues, Doctors Amin Yazdani, Marcus Young, Phil Bigelow, Veronique Boscart, and Badine Naruzikia. Also like to thank our research assistants, Sarah and Jenny. And also our research partners, County of Renfrew Paramedic Service, Peel Paramedics, Alberta Health Services, Paramedic Association of Canada, Public Services Health and Safety Association, and most importantly, I'd like to thank all the participants who volunteered for these studies. All right, so that's all that I have for today. I'll turn it back over to Corey to facilitate our question and answer period.
Okay, thank you, Bronson, for a great presentation. And thank you to those of you who have submitted questions so far. If you do still have any questions, please just submit them now and we will get to them. We do have a few here that I'll get started with. So the first, someone was hoping you could elaborate on what the implications of this research is for paramedic service organizations.
Yeah, sure. So a lot of this research has been pulling together a lot of the stressors and mitigation strategies through regular operations and during the pandemic. And so what we're able to now do is develop this guideline where we can have a more comprehensive and integrated approach to addressing OSI in the workplace. So that's something we'll go over a bit more in the next webinar series, where we'll talk about these essential pillars to developing the foundations for addressing OSI in the workplace.
Okay, that's great, thank you. And then I do have a question here asking if there are any plans to follow up with the interviews and paramedic service organizations to see what they have learned throughout the COVID-19 pandemic.
Yeah, we're working with this idea right now of developing kind of like a reflection tool for paramedic service organizations in combination with the guideline that we developed. So this allows organizations to reflect and look back at what they've done for this pandemic. And if we can develop these partnerships to continue reaching out to paramedics, and if they're willing to share this type of information on their reflections of how they responded to the pandemic, that would be a really, I think that would be a really cool study to talk about and provide a lot of lessons learned from various organizations.
Okay, great, thank you. I believe that was our last question. So just as we wrap up, I would like to bring everyone's attention to our upcoming webinar schedule. So please visit our website or social media channels to find the schedule, and they're up on the screen now if you want to take a picture or screenshot. But on our website or social media, you can find the schedule and the registration links. So we hope to see you at our future webinars. If you happen to miss a webinar or you can't make it to one of them, you can find all of our past recordings on our YouTube channel. So that is at CISWP. And we will be uploading our webinars from the work from home series as well as the paramedic series. So thank you again for everyone for taking the time to join us today. We hope to see you at our future webinars of this series as our researchers will be discussing their findings in more detail. Thank you, and I hope you all have a great rest of your day.